Hello, everyone. I'm honored to speak today. I've presented at conferences dozens of times before on this technology over the last 8 years, but this is the very first time I've ever presented at a medical conference. Also honored to be invited here to speak today by Jessica and Shlamit here after a one-year FDA review process. I'm glad they are still putting up with me. So with that, the reason for that this is the first medical conference I present at, I'm not a physician or researcher. I'm a bioengineer by background, as Jessica mentioned, and turned entrepreneur. So I have a very significant disclosure, which is I'm the co-founder and CEO of DermaSensor. It's an AI-based skin cancer device. That's the subject of my presentation today. I did my best to put my old engineering hat on, though, and keep it as scientific and objective as possible, even though my day job, especially following FDA clearance a couple months ago, has very much been to pitch and promote the product and company, but did my best to put the objective scientific hat on. So with that, what started as a 30-pound microwave-sized spectroscopy device, when I started with the company 8 years ago, took a few years to miniaturize that into what we have today. And it's used to non-invasively take optical tissue samples of the skin lesion, and the algorithm provides an immediate assessment of the spectral features and associated malignancy risk level. In total, we've completed about 13 studies with this technology for skin cancer. About half were used to develop the algorithm, other half to validate the standalone performance and assess how it impacts or benefits physicians. Some studies involved all 3 skin cancer types, some were specific to melanoma, since the device was developed to be effective across all 3 cancer types. While most of the device validation studies were done with dermatologists, given the high volume of skin cancer they're able to assess, the device was really developed to assist non-specialist physicians in deciding which lesions to refer to dermatologists. Obviously, that's in keeping with the long-standing goal of the dermatology community in trying to get PCPs better at effectively assessing skin lesions and prioritizing high-risk lesions in patients to dermatologists. So the device provides a binary output. Investigate further is a positive results, and monitor is a negative results. For positive results of investigate further, there's a 1 to 10 scale that indicates the degree of malignant features in the scan lesions, and we'll kind of talk about the results here in a couple minutes. But first, the technology works. Is it booted up? Okay. I'll just do a quick demo here, show it in action. The technology works by pulsing hundreds of wavelengths of light, basically every 10, oh, wait, I didn't click forward. There we go. So the technology works, pulses hundreds of different wavelengths of light, about every 10 nanometers, pulsing light, measuring the backscatter reflectance. So similar to, in a sense, to the talk that was given just before this. Mostly visible light between 350 and 850 nanometers. And so practically kind of how it's operated, first step's a calibration step, making sure nothing's blocking the fiber optic probe tip. And okay, great, calibration complete. And the subsequent steps are, I just gotta hold it this way. Taking 5 tissue samples or optical recordings, each one. So you basically, put it up and down at different points in the lesion, and we have instructions on that and the instructions for use. Okay, 5th sample, processing time's about 4 seconds. And then you get the result that you saw on the last slide, right? Either a negative result or a positive result. So that's kind of the whole process for use. And it's helpful to, I think, see the device work and understand that it's not taking photos, right? There's kind of these point light-based recordings or measurements. Okay, where was I? So these differences that you can see here in these different pathology groupings, so melanocytic benign, melanocytic malignant, non-melanocytic benign and malignant, are really based on cellular and subcellular features like nucleus size, melanocyte density, presence of condensed chromatin. The same things that a derm path is looking at under a microscope reflects photons differently to their eyeball, also reflects photons differently to the microspectrometer, which is the handheld piece I was just showing. So you can almost think of it, thinking back to mass spec, similar to how electrons reflect and mass spec, or a more general comparison we'll use to explain to PCPs and patients sometimes, like it's almost an optical version of sonar or ultrasound in a sense, kind of pulsing light to assess the features or environment. And because the device does not take images of lesions, so it's really complementary to physicians' visual assessment, right? Because visually they're looking clinically or with a dermatoscope, so this is using AI to analyze information or data that literally cannot be seen or assessed with any visual modality. And also because it's not using surface level data, unlike photos, the optical literature and also our clinical studies suggest that skin's melanin does not impact device performance, since device performance has been observed to be similar across lighter and darker skin types. But I do want to be clear, we haven't done studies specifically powered to demonstrate that performance is the same in each individual skin cancer type. That's especially hard to do, as everyone knows, given the low incidence of skin cancer in darker skin types. But on the AI front, so with regard to the techniques used, the technology really uses a variety of algorithmic approaches and also multi-class outputs that take into account malignancy features and melanocytic features, since the technology needed to be sensitive for all three cancer types, especially given that it's intended for non-specialists. You don't want to detect melanoma but falsely reassure primary care physicians that basals or squames are fine, for example, right? So the diversity of AI approaches really allow the model to be more generalizable. The analogy we like to use to explain that is using different neural net architectures is like receiving a diagnostic consensus from multiple doctors instead of one doctor, and multiple doctors that are trained at different institutions, right? Kind of that's the idea, is you're kind of querying multiple opinions and multiple opinions that were trained in different ways. Also, literature suggests the nature of the technology makes it highly generalizable for varied users, since it only analyzes one-dimensional data. So the light reflectance that you saw on the other slide is a number, right, that the algorithm analyzes, whereas in imaging data, in contrast, as everyone knows from your practice, highly rich with different features, and sometimes can overfit on noise versus signal due to image quality or type, different cameras, color variation, different lighting, et cetera. And so, the data used is one-dimensional, just zeros and ones, basically. And so because it's simpler, also requires fewer lesions to train the algorithm. So yeah, I think kind of what my understanding from folks that know a fair amount about both imaging and spectroscopy is that's a key difference, kind of the different in dimensionality of the data, because there's so many biomarkers in photos or image. And I think I imagine this will be discussed a bit more in the discussion after, but I imagine that's part of why there's not any current image-based AI tools that are FDA cleared or approved that are available for use to clinicians, even though, of course, there's been publications on this for 35 years. The first one was in 1990. And of course, dozens of companies have pursued this for 20 plus years. In the primary care pivotal study, so this was 22 study centers, 1,000 patients, led by Mayo Clinic. For a negative device result of monitor, there's a 97% chance of the lesion being benign. And remember, that's benign or negative for all three cancer types. So for melanoma only, of course, it's the NPV is higher. For positive results and investigate further result, remember there's that investigate further is positive, and then there's that 1 to 10 scale. The likelihood the lesion was cancerous ranged from 6% for a score of 1 to 61% for a score of 10. So kind of a tenfold increase in malignancy likelihood was found in that study. Translating that to terms that clinicians are more used to, the number needed to biopsy for a lower score was, what is that, 6? I think like 14, whereas at a higher score was less than 2. It was like 1.6 to 1. And we saw similar results in a melanoma validation study with 10 dermatology study centers that Dana-Farber led. The NPV for melanoma was just over 98% for derm biopsy lesions, and the PPV for melanoma ranged from 10% for low scores to 47% for high scores. So the NMB for melanoma ranged from 10 for low scores and it was 2 for lesions that were biopsied that had a high score. So the clinical evidence that has been used with regulators globally consists of 6 main studies, and there's kind of 3 types of studies. 2 that show the device sensitivity and overall accuracy is measured by area under the curve, is comparable to that of dermatologist in-person dermoscopic assessment. 2 that show the device had superior sensitivity and accuracy to that of PCPs. And 2, but when you think about it, it's not really device versus doctor, it's physician aided by the device versus physician with only their unaided, right? Their standard of care alone. That was spoken about, I think, a couple of earlier presentations. But so the last 2 show physician aided performance versus physician unaided performance with their current standard of care only. And again, we saw higher sensitivity and accuracy in those studies as well. So here's the specific device that was cleared a couple months ago by the, specific device indication for use cleared by the FDA. So essentially an assistive device to inform referral decisions for lesions that physicians have already identified as being suspicious for melanoma, BCC, and or SCC. Because sometimes PCPs, they don't really have clear differentials in mind, like, oh, it looks funky, looks odd, I'm concerned. While most of the device clinical studies have been done in the derm setting for training and some initial validation, the FDA submission, and thus the FDA clearance decision, to be clear, was based on the risk-benefit assessment for physicians who are not already expert in diagnosing skin lesions, so who are not dermatologists. And workflow-wise, essentially the physician proactively, and often PCPs, it's reactively, identifies lesions, identifies a lesion or lesions of concern, conducts a clinical assessment to determine if they are suggestive skin cancer, and if so, then scans the lesion with the device, receiving that output, and then deciding how best to manage the lesion in patient. So here's 2 examples that I imagine are fairly easy for most of you, but PCPs can be much trickier. So these were used in one of the reader studies for the device, and both of these are high-res photos that they were able to zoom in on. Obviously, you can't kind of do that live here, but and I can imagine many of you can relate to how PCPs often have challenges with lesions like this, and you know that from unnecessary benign nevi and SK referrals you receive, but you can also relate to receiving skin cancers referred to you that often could have been referred much earlier. And just to confirm, the left case is an SCC and the right case is an SK, in case you were wondering. So in summary, the device is intended to help PCPs better detect and prioritize referring high-risk lesions to dermatologists. The device effectiveness has been demonstrated across thousands of biopsy lesions with dozens of research centers, and the benefit to physicians has been shown in reader studies with hundreds of physicians. The device has been shown to have high sensitivity when compared to that of dermatopathology, and has been shown to increase non-specialist performance for assessing and managing suspicious lesions. Thank you.